Good afternoon. Welcome to the second of our webinar, Meet the Innovators with Carolina Garcia. I'm Cristina Vescosa. I'm the Managing Director of EIT Health Spain, one of the innovation hubs of EIT Health. I just, as a reminder for the audience, please use the Q&A section that you have at the bottom of your screen to make your question. There's no possibility to talk live here, but we will read out the questions after the presentation of the speakers. So today we have here one of the projects that has been supported by EIT Health on the rapid response call against COVID-19. So you know, we were all in Europe affected in the beginning of March by the pandemic, and very fast EIT Health moved with EIT, a new call on rapid response to really response that could have results within the year. In less than 6 weeks, we had the possibility to make 7 million euros available, and the call in the end, with all the applicants, we were able to award 15 projects. We have today Carolina Garcia, who will present one of these 15 projects, which is the Digital Control Center for COVID-19. Dr. Carolina Garcia Vidal is a senior specialist at the Infectious Disease Department of Hospital Clinic in Barcelona. Among others, she has won the Young Internist Award for Research by the Spanish Society of Internal Medicine and the Young Investigator Award by the European Society of Clinical Microbiology and Infectious Disease, of which she is currently member also of the Scientific Affairs Subcommittee. Her research is in respiratory tract infection, especially in immunocompromised host infections. And in the recent months, she has started several projects in artificial intelligence and how this applies to medicine. And she has become one of the leading sources of reference in this field. And that's why we are going to have the next meeting with her. So Carolina, the floor is yours.
Thank you very much, Cristina, for this nice presentation. And I'm going to talk about what we have done, that is the COVID-19 Control Center. And the history starts here. This is my hospital, and more or less here, there is the Infectious Disease Department. And I perfectly remember 18 February, when the first case of COVID comes from the Fashion Week from Milan. And I think the history is very familiar for all of us. No? We have been living a very difficult situation. One of the, a very severe pandemic. And I can tell you, for example, that one day we have more than 2,000 patients under our control. So it was really difficult to work with that. So we decided that we fight against this infection using innovation. During the past 2 years, we have been working in artificial intelligence, or working to prove that artificial intelligence may help in the clinical decision-making process. And the milestone of our project is this tool that we call SIL, that is an intelligent system to read and provide high-quality pieces of data from electronic health records in real time. It's really amazing, no? We are working with our computers in the electronic health records, and all the information that is new generate in real time, we have available in a data lake ready for analyze. So in a very few months, we have more than 3 trillion pieces of data from patients with COVID. And of course, that allow us to do many research and also help of patients. This is our COVID seal, as you can see here. I love it. This is our seal, but I still feel very proud when I see you only ticking different points. We have in real time, we have all the information that we want, and the gender, the years old, if the patient has been admitted in ICU, the respiratory rate, etc., all the information that you want. And if you push in the 3 points that you have here in the top, we can transform this information in a SPS program, CSV, or whatever format that you want to analyze. We have now more than 2,200 patients information about 2,200 patients, more than 5,600 variables of these patients. So after clean all the data, we have close to 12 millions high quality pieces of data. And these data are being updated in real time. We have created a dictionary explaining these 5,600 variables, what means. And probably for me, this is the most important slide in my presentation. All the data had been to be all the data needs to be okay in these 9 steps to assure the quality of our data. So when we arrive to the end that, okay, we approve this data, the 100, we can assure that this data have a 100 optimal quality. With that, of course, we can write many papers helping our patients with more than 30 points of impact factor in the most important journals. We have really agreed, or we are really grateful with AT Health for this help. And with all this project, we were able to create a control center. What it means? That means that in one computer screen, we were able to see what was happening in all our patients with COVID, and we were able to order these patients by PCR, gender, age, or whatever we want. No? In one tool, well, here you can see that you have 500 variables. With this information, we were able to create new knowledge that probably now it seems that is very easy, but in March we have no idea about that. For example, no, that the patients when had infection, some of patients had viral symptoms and another are asymptomatic, and we have no idea what. But what we discovered with this project was that when the patient had a severe condition, the patient may have different complications, may have inflammatory pattern, superinfection pattern, or thrombotic pattern. And the most important one is that all of these different complications have an specific analytic pattern. So what we did was put all computers following this different pattern and program all our computers to make something like this, that is a map about what is really happening in real time with all our patients in the hospital. So looking at this screen, you can see, wow, this patient in this room is starting an anti-inflammatory pattern. So we run to the patient and start a personalized treatment for this patient. No? How we work, we have 5 different patterns, or we were able to recognize 5 different patterns. These 5 different, we had a report all the times that we push one button, so it was in real time, and this report was given to the infectious disease department physicians, and the infectious disease physicians went wherever it was in the hospital to say, hey, be careful, your patient is starting a superinfection pattern or thrombotic pattern, so we have to do this, the one, or this other. And with all the data that we have, we perform different neural networks to create the optimal cutoff points for each of the patterns. Using this personalized treatment, we have been able to reduce the mortality of our patients, of the most severe patients, in more than 80%, and all core, the mortality decreased in 50%, independently of the increasing age or the therapeutic effect limitation. Now we are working with this application with this mobile application, who had all the information. This is the center, the control center. As you can see here in red, you have the patients who need a fast medical response. No, orange means it's more or less like this, and green means this patient is okay, can be safely and objective discharged without any problems. We have also a website where we can see all the parameters in a bigger site, but also we can create different graphics for follow-up. So what we have done has been to put an intelligent system on the top of our electronic health records, who was able to follow what was happening in all the patients, and that is able to help the physicians in the decision-making process. Thanks to the AT Health grant, we have been able to share this project with other 4 hospitals, so the scalability has been done in a very good way, and all these 5 hospitals now can have the same control center for COVID patients. I'm finishing here my presentation, and I'm open for your questions, and thank you very much for your attention.
Thank you very much, Carolina. Impressive project, and also very impressive results in the short time that you developed the algorithms, and also considering that it was in the middle of the pandemic, in a huge crisis situation that the hospital had. So we are very impressed about the project, but it's also about how you have been to develop this innovation in the situations that you had. So from Spain, we are also leading an initiative called Innovator that is about how really innovation can happen from the doctors themselves. No, and sometimes for the clinical career, we know clinical practice is recognized, definitely research, but innovation is not such an easy pathway, and you've done it in a very fast way, and you're able really to deliver results within 1 year. So I wanted to understand also from your experience, what has happened in you, and also what has happened in the hospital to support, probably to do this process and be able to really maybe dedicate some time or really push innovation, apart from probably you are doing your normal clinical routine, no?
Absolutely. You can be sure that, yes, I'm doctor 40 hours by week, and innovator 40 hours more. No, but yeah, it's very important to keep in mind that we had been working on this project from 2 years ago. So when COVID arrives, we were ready to change all the things that we were doing and to adapt our technology to COVID, and that makes that our way has been very fast. That's the truth. Of course, and this is very important, and I want to be very grateful with that. The help of the board, of the directors board of the hospital has been amazing. If you have not a hospital who work all on the same way, because you need people from computing, you need people from the law system. You need many people, in one project like this. So the hospital support has been amazing. And well, innovation is something difficult for doctors, but I like to say that innovation is not the future. Innovation is the present, and we have to adapt to that.
Yeah, definitely. I want to remind the audience that you can make as many questions as you'd like. Just use the Q&A section at the bottom of the screen, and you can type there your question. I will read them out for Caroline. In the meantime, while we receive some questions from the audience, I will continue a bit of understanding how has been your journey in the last months. And one of the things we've seen around COVID also is there has been a huge amount of information and research and new knowledge around COVID and the treatment of COVID. And I wanted to also understand how this has affected your project. Have you learned from the experience of others? How have you shared others? What has been a bit your experience compared to the previous time, this high intensity exchange of information and absorption of it, no?
I love this question, Christina, because I think COVID tested us and proved that we need computer support for doing our job. For example, one example that is very clear is that we have in mind that COVID is one disease, but this is not true. As I showed you before, each patient is happening for a different process. So you really need to personalize medicine for these patients. And this has been one problem in many trials and in many papers documenting the impact of different treatments. Why the people is asking remdesivir is okay or is not okay for patients? Because when you analyze what happened with remdesivir, you put on the same bag many patients with different problems, and this is a mistake. This is not the forum, and I don't want to share here because it was not what we have to do, but we have been using artificial intelligence to create clusters of patients that are equal in conditions to analyze which one is the impact of different COVID treatment. And the results are very, very interesting. So if you want, we can share the information in a few times, but this is provisional information and we have to keep some prudency. I don't know if this is good in English. We have to be prudent.
I understand. So let's talk about a bit how, from your learnings at the hospital clinic, which is a very unique, international reference center and also one of our core partners at the EIT Health Spain. Wanted to see how about the scalability, how we can really use it for other hospital, and how, was that EIT Health supporting that, and what is your experience? Especially, you have worked with very different hospitals, some around your area, probably with a similar healthcare system, some of them more or less known. Yeah, go ahead.
Similar healthcare system, but absolutely different electronic health records.
Mm-hmm.
So
okay, that's interesting. And then you have worked with a hospital in Louvain and also Erasmus Hospital in Rotterdam, so completely different healthcare system, different culture, different experience. So tell us about that international experience.
The experience has been great. In fact, we are a team who is used to work in an international project. So it has been not a surprise that to work in an international teams is very good, but it's very important because you learn from different points, and this is all more for your project. We are really grateful to Haiti Health, because one of the most important things that they do is to open the doors to provide these networks. And one thing that has been very interesting is that we have been able to prove that when we are creating computers tool for health, what you have to do is to define very good what you are doing, and after to use different connectors that make able that this tool can be used in different electronic health records, different countries, different language, different wherever. And well, it has been a test, but it has been, I think this part has been easier than we think at the beginning.
Okay, interesting. And what do you think has been the most difficult part of this collaboration, of this mixture? And especially, considering that you have done it in the middle of the COVID and then suddenly came the second wave and so on, so probably all the plans have been to be agile and readjusted, no?
Well, I think our team has been very good, and I want to say thank you to all the hospitals because the collaboration has been 100%. But probably the most difficult has been with the law and to be sure that we are not breaking any ethical rule. It's true that we work with data in the hospital servers, so that data never go out from the hospital, so it helped us so much. But I think that has been the most difficult problem, because with all the other steps, to do some project with this high amount of data, of course it's difficult, but it has been a very good experience.
Mhm. Tell us, Carolina, then about the next steps. So you have tested this now for these 5 hospitals. What are the next steps?
Well, we really would like to share this application with all the hospitals who want or who are interested in that, and we open the doors because, of course, we are all fighting COVID-19, and we will be very happy to if we can help more people. No, about from now, how is scalability? Well, we will see. We have, for example, different offers from local and also national governments. So we will see what we can do, how they can also help to the project. We are working on that.
Mhm.
Really, for doctors, we don't like this part of this part of the job, no. But we have to,
The the key part of your development is this seal, is this tool to really extract the data in real time and ensuring the quality of the data. I understand you've been able to do that at the hospital clinic. It's not that easy, that part to implement completely at a new setting. I'm just asking, or what would you recommend for a doctor who is at a new hospital and would like to use something like that? What should be the steps to develop something?
you have to think that the shield is a live tool, no? Because you are putting new information every day. So no, and you have to feed this tool every day. You have to be aware that the definitions doesn't change. For example, no, if you have a new laboratory test, or a new drug, no, you have to add these definitions, no. So the seal is a program, and your hospital has been very convinced that they need a minimum people working in this program. No? After that, the most difficult thing in the seal is the definition, and to put in the same way people from computer and people from medical skills. And when you do that once, we did in hospital clinic, after the connection with different hospitals, it's relatively easy because it's again the same. No, when we are talking about age or about gender, no, the definition is the same. No, the thing is that in hospital clinic, this is here in that point, and in liver, this is in another. So, well, this is a very hard work. It has been a very hard work, but I think also we have to try to the scalability for our seal, because if we prove that we can put one seal able to read more than 3 trillion pieces of data in another hospital, that will make a huge, huge change for the medicine, I'm sure, because imagine all the hospitals working with trillions of data on real time. That will be amazing.
Yeah, I
High
wanted to
quality.
also ask
Well,
about these changes of processes in the hospital, because one of the things we've seen with COVID that it affects different departments, no? Because you can have respiratory problems, or you can have cardiovascular or other inflammatory. So it was needed by itself a really across disciplinary, interdisciplinary approach. How has this tool helped to keep that in mind, or it is was that already part of the culture of the
absolutely.
hospital?
At the beginning of our work, one of the things we starting looking for which one were the variables needed for clinical research. And 90% of variables are equal from infectious disease physician, cardiologist people, pneumologist, and whatever you want. No? So what you have to do is to have a seal providing information, the most information that you have about your patients. And after that, no, you can ask to this seal different questions. Of course, my questions are all about infectious disease, but the questions from the cardiology department will be about cardiology, And asking these questions, you have to create the algorithms who answer the question, and to put this algorithm in connection with the cell, so you have the answer. No? And that's the way that we are creating the smart hospital program in hospital clinic, no? With this escalator that is sealed, and after that many different departments asking different things and creating many multiples algorithms to answer these questions. But now we only have open the COVID part. So that will be the project probably for 2021.
Yeah, and so that's what we are seeing, that this was just probably the start of many new algorithms and new way of working with artificial intelligence at your hospital and in the collaboration with other hospitals. So, are you planning to continue these collaborations that you have established with the different hospitals and also with EIT Health in the future around this line?
Yeah, we love it because really our experience has been very good, no? And EIT Health has helped us in 3 ways that has been very important for me. The first one has been, of course, economical way. The second one has been in the creation of the network, and the third one has been that really you amplify all the results. This is very important for all of us, no? So we have feel very comfortable with the team created with Liven and with Erasmus. We also have many. I really like to add more people to this team, but of course, my feeling is that this is a starting point, and I'm always saying research, and I know that it also happened in innovation. You close one door, and 3 doors are open. No, so.
Yeah, I think once you start the path, you cannot stop. No, I think if
Exactly.
you get addicted to innovation, you will see that. Okay, Carolina, I think it's time for closing this second session. Thank you very much, Carolina. I think impressive results, and say the COVID Digital Consult Center is one of our flagship projects related to the rapid response against COVID-19.
Thank you very much.
So I would like to also thank the audience for keeping with us this half an hour, and I will encourage you to follow the next midday innovator session. There's one specific session about Expert 3D. So the experience of the Sant Joan de Déu Hospital in Barcelona about 3D printing with Dr. Josep Munuera and Arnau Valls, and also moderated by my colleague Montse Delgado from EIT Health Spain. So we hope to see you also at the summit in 2 days to continue the sessions. Thank you very much. Bye-bye.